For the next hour, we're going to be talking about home sleep apnea testing as it is in 2014. And I thought this was appropriate for this time of the day. No matter what time it is, wake me, even if I'm giving a sleep apnea speech. So first of all, I want to talk about terminology because it's very confusing if you look at the literature. The traditional terminology has been portable monitoring or ambulatory monitoring. However, CMS will always refer to home sleep testing. American Academy of Sleep Medicine actually calls it out-of-center testing. And I think all those are bad because really, for the most part, when we're doing home testing, it's only for sleep apnea. We're not really doing a home sleep study. So I prefer the term home sleep apnea testing. So what are the driving forces for sleep testing to begin with? And you've heard it many times that the rate of obesity in the United States is extreme. It's doubled from 1990 to 2012, and there's different numbers given, but mine was 28%, but I've heard somebody say up to 35% as of today. In addition, over the last 20 years, there's been more and more studies that confirm the importance of obstructive sleep apnea as a comorbid condition for lots of disease processes, whether it be diabetes, hypertension, coronary disease, cerebrovascular disease, etc. There's also been an increased awareness of the importance of sleep deprivation that's caused by obstructive sleep apnea and its effect as far as motor vehicle accidents or on-job performance or cognitive performance. But I think probably the most important change that has driven this is the technology itself. When I was at Baylor about 6-7 years ago, they still had one of the original sleep testing machines. It looked like the telephone exchange from 1920. It was huge. And the reality is now you can get a home sleep apnea test that's a very small device. And because of this mass need, industry has gone nuts. Every manufacturer has gone ahead and developed things, and there's really been nobody back there pulling the strings on how to develop. So there was all these different types of monitors developed. And then, of course, they mass marketed it, not only to the general public, but to all the providers in the nation. So let's just look at accredited sleep centers in the United States. In 1996, there were only 337. By 2006, 10 years later, 1,096. And by 2012, 2,500. And this is a drop in the bucket, because the reality is there's probably 2 to 3 sleep centers per every one accredited sleep center. And then the home sleep market is an entire logarithmic curve on that. So how about money? So let's just look at Medicare. Medicare spent $62 million just on sleep testing, not treatment, on 2001. By 2005, that number was up to $215 million, and by 2011, $565 million. So is home sleep apnea testing new? No. This is from 1994. The American Sleep Disorders Association recognized home sleep testing, but said that it should only be done in patients with severe symptoms when the need is urgent and a polysomnogram was not available, or in patients that couldn't be studied in the lab. They were too sick, they were immobile. And then lastly, is it required a follow-up study after diagnosis by polysomnogram to evaluate response. 2003, the American Academy of Sleep Medicine, American Thoracic Society, and American College of Chest Physicians actually set a practice parameter that said type 3 studies, which is probably the most common home study that we see today, was acceptable. However, it had to still be attended, meaning that it still had to have a tech there. And again, it was not to be used for general screening or for patients with comorbid conditions. So the Institute of Medicine report was generated in 2006, because of this large need that was perceived. And they looked at that there's this huge disparity of availability of polysomnograms depending on where you lived in the country. And for the most part, all the sleep labs were in urban centers. So there was inability for diagnosis in rural areas. In addition, there were long waits. And this was especially true like in the veterans, which would literally be a year to wait. And I know even today at Alaska Native, it's a 6-month waiting period. Polysomnograms meet only 25% of the need back then, and it was perceived that less than 20% of the patients were being appropriately diagnosed. So again, another task force came together, and in 2007, they said, yes, home sleep testing is an alternative in the diagnosis of sleep apnea if there's a high probability of moderate to severe sleep apnea. It's not appropriate in if there's comorbid medical conditions or comorbid sleep disorders, and it's not appropriate for general screening. It may be indicated in patients, again, who cannot get into the lab because of illness or immobility or even safety issues. But it also can be used to monitor responses to non-CPAP therapies such as oral mandibular advancement devices. But the major change really occurred in 2008 when CMS changed whether they would pay for the CPAP by what was done to diagnose. And that was the time that they said payment for CPAP would be covered after a clinical evaluation accompanied by either a regular attended PSG or an unattended home sleep apnea test with a type 2, type 3, or type 4 device that measured at least 3 channels. And in 2011, it took another 3 years to really get billing codes for that. And the first 3 billing codes are the G codes, and that's for type 2, type 3, and type 4. Those are the technical codes. The interpretation codes are the CPT codes, unattended with sleep time or unattended with analysis. And it's important to realize that a modifier on these was payable only when used together with a G code, and billing just a technical component of this or a full global of this would be denied. So the other part of that is the data service and where the study was performed is important. So if you're going to bill a G code, it really is the data the sleep study device is applied, and it has to say, as the place of service, the home. The interpretation code is going to be billed as an office code. And these 2 codes should never be billed on the same date of service because that would be impossible to do. So you will get denied if both codes have the same date of service. The interpretation date should always follow, obviously, when it was attached to the patient. So let's look at classification of home sleep studies. Well, first is not a home study. This is a regular study. Type 1 study is a fully attended PSG, has to include methods of sleep staging, including EEG, EOG, EMG, and ECG. And it also has to have parameters for airflow, respiratory effort, oxygen saturation, and can be performed, as you know, as either a split night or diagnostic study. A type 2 device is similar, only it can be done in the home. Again, it has to have a minimum of 7 channels, but you have to have the ability to do sleep staging. So it has to have EEG, EOG, EMG, ECG, airflow, respiratory movement effort, and oxygen saturation. The most common device used out there, and the devices we use in our lab, are type 3 devices. And these have to monitor at least 4 channels and up to 7 channels. And includes respiratory movement effort, airflow, ECG, and oxygen saturation. And lastly, the type 4 device. And this has a minimum of 3 channels and must have some way of directly calculating the AHI or RDI by either airflow or effort belt. However, other alternative devices can be approved if there's literature that supports their use. And an example of this is the watch pat. And the watch pat's unique in that this is actually, as shown, sits on your wrist. There's no airflow cannula, and it actually measures peripheral artery tone. And then that peripheral artery tone mirrors changes in the autonomic system such that the detection of apneas or hypopneas, REM approximation, and sleep architecture, and it allows a calculation of the RDI and AHI using sleep time rather than test time. These are used in a lot of dental offices where I see them, and I don't know about the rest of the country, but that's where I've seen most of them come when I see reports from these. But it is interesting, as far as if you look in the literature, as far as testing of these devices, the watch pat's the only one that I could find that actually has a study that looks at obstructive sleep apnea in pregnancy. And in this published study in 2012, they took 37 pregnant patients in their third trimester, and they excluded the data from 6, secondary to some technical issues, and they put a watch pat 200 on at the same time they did a PSG. And they found a 96% correlation in diagnosing OSA if the AHI was greater than 5. However, they also came to the conclusion that the sleep staging of these devices was poor, and they tended to overestimate the RDI at the higher values. So this is an example of a type 3 study, and we see a lot of these in this state, apnea links, and this is a ResMed product. And again, it measures respiratory effort, pulse oximetry, and airflow. And you can see the cost of this unit's around $2,500. Respironics equivalent would be the Stardust 2. Again, it has an airflow sensor, an oximeter, an effort sensor with a single chest or abdominal effort belt. It has the ability to actually tell if the lights are on and can track like the bathroom visits. And then it also has a position monitor, so you can tell if the patient's supine or non-supine. This is the unit we use, and this is the Alice PDX, which is an upscale model of this. Now this has the capability of doing a type 2 study, not with what you see here. What you see here is the type 3 version, but if you attach another yoke, they have an EEG yoke on it and an EKG yoke so that you can get up to 21 channels. But even for a type 3 device, I personally prefer this over their own version of their type 3 device because it has 2 effort belts, so you both have an abdominal and a thoracic belt. And it also has a thermistor in addition to the airflow cannula. But you can see the cost is significantly more. Oh, one other thing on that is you also have the ability to interface this with an APAP to actually do a home titration. So, you know, you can, I personally think, at first I thought it was a gimmick, but now that I've done it a few times, I actually think you can open up that study and actually get more information out of it than you can by just putting somebody on AutoPAP and pulling their card in 2 weeks and doing a download. This is Embletta Gold, and the reason I put this up there, just like the Alice PDX interfaces with Alice software, I don't know of anybody in this state that's using Embletta, but I know like Atlanta uses Embletta, and this integrates with Sandman, and it would be the equivalent. It can do both a level 2 or level 3 study, depending. I put this one up here because it's also a unique one, and this is the Watermark AIRS Unirecorder. And AIRS is an acronym for Apnea Risk Evaluation System. Now this one actually is worn on the forehead and uses oxygen saturation and measures the pulse oximeter as the primary signal. Then it actually analyzes the change in pulse rate, snoring sound, head movement, and the slope of the resaturation curve to identify behavioral markers of arousal that follow desaturation. They plug that into the software and it analyzes the physiologic signals and combines them with data that you get from a risk questionnaire addressing age, gender, BMI, neck circumference, drowsiness, frequency of snoring, observed apneas, and history of hypertension, and comes up with a risk. Now the assumption with this is that the desaturations are always terminated by arousals resulted from obstructed breathing. And so obviously if the arousal were from periodic limb movement disorder or something else, that would make it less accurate. So again, they have data that confirms its effectiveness. And this is from 2005, where they looked at 284 subjects, and they concurrently obtained data acquisition with an AIRS unit and an in-lab polysomnogram. And they found a sensitivity of 97.4% and a specificity of 85.6% if the cutoff was an AHI of 10. Not sure this thing works anymore. In the home setting, if you increase the AHI to 20, the sensitivity stayed about the same, but they actually got a specificity of around 100%. And then I'm just illustrating that every manufacturer now has a family of sleep apnea testing devices, from a type 1 study, type 2, and CleveMed here has actually two different type 3s. There's one 9-channel and one 3-channel. I put this in there just because I think it's unique. CleveMed actually makes the Dreamport, and I've never actually seen one of these, but this, you send the whole thing out to wherever it is, maybe a clinic out in the bush or home or wherever. They set it up, and then hook it through the internet, and it's got a high-quality infrared video, and you can do a telemedicine attended sleep study. So I thought it was unique, and I can see where, I kind of like to play with this just to see, but I don't know if any other manufacturers make anything like that. So it got confusing. There's all these different devices out there. So what do? When you're confused? You develop a task force. And so American Academy of Sleep Medicine got a task force together and decided to determine a more specific method of classifying and evaluating sleep testing devices. Now, the scope of this work was limited to the classification and evaluation of the performance characteristics of the technology itself, and not really directed at any specific unit, and did not address use in practice guidelines, accreditation standards, or management principles. So the conclusion was, as far as what worked and what didn't, is if you used a thermal sensing device as the only measure of respirations, then you needed 2 effort belts. If you use nasal pressure, depending on that device, that may be adequate alone, or you may need 2 piezoelectric belts, or you may need 1 respiratory induction plasmography belt. They felt there was insufficient evidence that both a nasal pressure and a thermistor were required to successfully diagnose OSA. However, they did determine that a thermistor alone was not adequate. And with respect to alternative devices, the data did indicate the WatchPat, or the peripheral arterial tonography devices, were adequate. So I'm not sure how that helped us, really. But they did determine that methods dependent on end-tidal CO2 were not effective. And there was inadequate evidence that acoustic signals or cardiac signals as a sole signal were effective. So what do you do when it's confusing? You have all this data, and you have a lot of smart people in one room. You come up with a new system. So this is what they came up with, and this is called SCOPER, and SCOPER is an acronym for sleep, cardiovascular, oximetry, position, effort, and respiratory. And then within that category, you can look at effort, they subdivide it. So type E1 would be 2 RIP belts, and E2 would be 1 RIP belt, and E3 would be some derived effort such as forehead venous pressure, and E4 would be some other measure, including piezoelectric belts. And so you can see each of these got divided from anywhere from 2 to 5 categories. So now it's clear. It is absolutely clear. This is what we have. So if we look at the apnea link, an apnea link is a S0, C4, oximetry 1X, position 0, effort 0, respiratory 2 device. So there you go. So what are the rules? There's a lot of rules out there, and I'm not going to use AASM's rules because it really matters what you get paid in this game. So let's just use United Healthcare Benefit Considerations, effective April 1st, 2014. Attended full channel polysomnogram performed in a healthcare facility is proven and medically necessary in patients not previously diagnosed with OSA with one or more of the following indications. So they're going to demand you to do a home sleep apnea test unless we have significant chronic pulmonary disease. Let's define that. For their definition, FEV1 has to be less than 60%. Neuromuscular disease or neurodegenerative disorders, not limited to Parkinson's, myotonic dystrophy, ALS, or MS if there's associated pulmonary disease. Significant cardiac disease, and they define significant as class 3 or class 4 congestive heart failure, uncontrolled persistent cardiac arrhythmias, atrial fibrillation would not count, by the way, pulmonary hypertension, or history of a previous CVA. And I love United, because the rest of us in this room would define morbidly obese as 40. United defines it as over 50, so I've got a long way to go. Most of the insurance companies will say if you have a BMI over 40, you can bring them in lab. And then obesity, hypoventilation syndrome, or any of the following complex sleep disorders. If you can document periodic limb movement, not sure how you document periodic limb movement disorder without a sleep study, but if you do have a history of restless leg, you usually can get that pushed through. A parasomnia that involves disruptive, violent, or potentially injurious sleep behavior. Narcolepsy, or history of central sleep apnea. It's also home sleep studies are contraindicated in patients or children or adolescents, and they actually define children or adolescents as less than or equal to 20. And you can get an in-house study if the results of your previous HST are indeterminate for suspected OSA or upper airway resistance syndrome. Or you've done the study 2 or 3 nights and you have technically inadequate information. Also, if the patient, you can document that the patient lacks mobility or dexterity to use the equipment or the cognitive impairment to read the instructions. Just aside, I've had very intelligent people that really have a problem with that last one. We have repeated a test up to 5 times on a very intelligent people. So let's say, how does now we're going to go from the diagnostic to treatment. How does home treatment of obstructive sleep apnea compare to lab treatment? So the 2 classic studies, we're going to do the latter one first, is the home PAP study. And the home PAP study was published in Sleep in June of 2012. And on this study, they looked at 373 participants that had high probability of moderate to severe sleep apnea by the clinical algorithm and an ESS score greater than 12. And they split them into equal arms. There was a traditional arm that went to a split night or diagnostic followed by titration, followed by a home arm with a level 3 device that then they put on 1 week of auto PAP and then fixed that CPAP pressure at 90%. At 3 months, they found PAP usage in the home arm to be 1 hour greater than the lab arm at 4.7 hours versus 3.7. Adherence greater than 4 hours, 12.6% higher in the home arm at 62.8 versus 49.4. And overall acceptance to PAP therapy, titration pressures, effective titrations, time to treatment, ESS scores were not any different between the two arms of the study. Previously, the conclusion of that was a home-based strategy for diagnosis and treatment compared with in-laboratory PSG was not inferior in terms of acceptance, adherence, time to treatment, and functional improvements. So previously, the VSAT study had already taken place, and this was published in May of 2011, and VSAT stands for Veteran Sleep Apnea Treatment Trial. And here was a real similar thing where they took 296 patients. They took 296 patients, divided them in-lab versus a home arm, and they used a cutoff of AHI of 15. If in the home sleep study was negative, they brought them into the lab, and you see there was 35 of those 135 that were negative, and did a diagnostic study. Out of those, only 9 were negative. the 26 that this had falsely recorded as negative were brought back and put in the home auto PAP portion. And then they followed them up at 1 month and 3 months. And the finding was the mean adjusted change in our mean CPAP per day was 3.42 for the home adjusted, and in lab 2.99. And I'd just say that I'm not sure that either of those is such a great number. But their conclusion was functional improvement with CPAP for OSA is not worse when treated in the home setting versus sleep laboratory. And the implications were home-based OSA diagnosis and initiation of CPAP is effective in treating OSA. You know, I don't know about the rest of the country. I only know about Alaska. So the veterans here had a tradition where you got diagnosed with a CPAP, and if you lived outside of the Anchorage area, they sent you a CPAP and a mask and said, good luck with that, in the mail. So you can see, at least my model, you're not going to have great compliance with something like that. So what does a home sleep apnea test miss in the regards to the diagnosis of OSA? Well, first of all, most of the time you're not going to have the ability to look at sleep channels. So therefore you cannot tell whether the patient's awake or asleep. In addition, if you can't tell when they're arousing because you have no EEG, you cannot determine respiratory related arousals. So I think the terms AHI and RDI are very inappropriate for home sleep apnea testing, because the reality is all references should be in a recorded event index, or REI, rather than AHI or RDI. So for instance, if you have 10 hours of study, that's a recording of 10 hours and you have 100 events, that would be an REI of 10. However, maybe the patient was only asleep 5 of those hours, so all of a sudden their AHI is actually 20, correct? So next, you cannot determine the effects of REM sleep on breathing for the same reason. So now, you can imagine that if you have a patient with COPD or some other problem, usually on a home sleep study, you can infer when they're in REM sleep because you can suddenly see that you have bearding of the oxygen desaturation curves and you have a lot more obstructive events. And you may or may not be able to determine the effects of position on breathing depending on the device. And lastly, depending on the device again, you may or may not be able to differentiate obstructive from central events. So I'm going to tell you about our experience with home sleep studies. And we went back the last 6 months and just looked at the diagnostic studies, home sleep studies we did, and reviewed the last 375 of these. We found the rate of severe sleep, obstructive sleep apnea, 57%, moderate 31%, mild 10.4%. And almost no normals, 1.6. So what does that tell you? It tells you that probably if you're doing your job as a clinician or referring agent and you're defining moderate to severe probability, you're going to have a vast majority of these turn out to be positive tests. So I always say the best time to use a home sleep apnea device is when you already know the diagnosis, but you really need to confirm it because nothing's going to get paid for in treatment of that patient unless you have a diagnosis. So we can subdivide that, and we looked at BMIs. Does BMIs make a difference? And you can see that for BMIs over 25, pretty much not. They're still all moderate to severe. The only group that was a little bit different was those less than 25, where there's a little bit more equal distribution across the mild, moderate, and severe categories. And then we can look at age. Does that make a difference? And the same is true. For the most part, if you're over 30 in our lab, those referred for home sleep studies were moderate to severe. The only group was those under 30 were a little bit more spread out. And I will say, you look at, out of 375 patients, we only had 6 normals, and guess what? One of those wasn't normal. One of those did have a high probability. And so we brought him into the lab, and guess what? He had severe sleep apnea, and so it just goes to show that we're probably not screening enough people. Is what my conclusion out of that slide is, because you never should have that skewed a result. So what pearls have we learned? Most home sleep studies are being done are not really being, the data being looked at, and it depends on which lab. But in our lab, we still manually score all studies, meaning we open up the data and the tech literally scores it just like an in-lab study. And I think it's really improved our success and quality of our studies. And that's controversial, and the makers of devices will tell you that they'll show you where their programs are every bit as effective as manual scoring when they look at quality, inner score variabilities. And then selecting patients appropriately is crucial. You know, if you're doing home sleep study patients on the young guy that comes in with snoring and his wife says, I really want him studied, it's going to be negative because he most likely doesn't have obstructive sleep apnea, but he may have really bad sleep disorder breathing that you're missing because he may have a normal AHI, but his RDI may be 35. Provide a safe environment for the unit because these units are expensive. And for us, we're sending them literally all over the state. We've had them, you know, picked up by one airline, taxied to another place, you know, and you really don't want to see $4,500 piece of equipment thrown around. Tracking system of these units is essential. And I'll tell you, we had absolute chaos in our office. We had all these systems, and we had our Excel program, and we were tracking. We had no idea. And you know, we went old school on this. We went back to the Dewey Decimal System. Now they're manually checked out, the time, manually checked in, manually, when they're scored, it's manually done, and when the interp is delivered to the provider, it's manually written in. And I don't know the perfect tracking system, but that's one of the options. And then also, we actually looked on putting GPS units on these. And the problem in Alaska is we don't have GPS coverage everywhere. So you know, like you do with your car or your iPhone, you know, you have GPS on it. Providing multiple methods of instructions will significantly improve your failure rate. So we spend a significant time doing a face-to-face instruction, including putting it on the patient, showing them every detail of it. There are written instructions. There's a DVD. We're developing a YouTube video. And lastly, is one of our employees is available 24 hours a day. So when they get home, if they have a question, they call. And then simple things like taping the pressure transducer, thermistor, and the oximeter on will make success because you don't have a tech to put it back on, so when it falls off, you're pretty well done. So this is an example, and you can see you tape your thermistor and oximeter on, or I mean thermistor and transducer on. Now this guy does not have the duct tape here yet, but duct tape works great. And notice also we have dual belts, and you have both thermistor and transducer, airflow transducer. Now when I was at chest conference last year, and this topic came up, I said, we put them in handgun cases. That's probably not the right thing to say in Chicago. But we literally use Pelican handgun cases, and you have the ability to lock them. And then we take foam and put them inserts in here and cut the foam inserts out. And it does two purposes. One, it cushions every item of your unit, but it also provides a fast inventory of your unit to make sure that when that device goes out, it's complete. And trust me, that was a problem too we had. They get it home and say, hey, you know, they didn't put the thermistor in here. So they'd get to bring it back the next day, and somebody would get chewed out a little bit. And, anyway. So practical considerations. Lost or broken equipment. Turnaround time. You want it to be short, but I don't think you want it to be ridiculously short. I don't think that people should get the results the next day because that means nobody's really looking at it. So if the patient goes home, and it kind of depends on us. Sometimes we send we tell them to do 2 or 3 nights. If it's on a weekend, do 3 nights. We'll pick the best data. We'll pick the one that looks like you had the best night, you know, not trying to skew data, but the one that actually had a full night's sleep with all the everything attached. But also then, you have to give time for the tech to score it, and you have to give time for me to look at it. So I say the turnaround time should be 48 hours. I think the maximum time should be 1 week. What do you do with technically inadequate studies? You should expect 10 to 15%, but I really think you should get it down to almost none. And I think it's possible. What do you do with the negative studies? We already talked about that. If you have a high index of suspicion, don't trust your home sleep test. Bring them into the lab and do a full, complete polysomnogram. And then how do you develop your referral source? And I think there's lots of ways on this, but to be honest with you, this is a good way to develop your resources or referral sources. Teach your peers. You've heard Dr. Jabahari talk about cardiologists are referring 2% of their patients. That's the biggest way we increase our business, is by teaching who is appropriately referred. So I just want to do a few case studies, and we're going to, don't throw us under the bus too bad, because these are studies that I picked that really aren't the greatest studies, okay? And it's for teaching points. So the first is a 34-year-old female with a BMI of 34.1 and an ESS of 10. She has chief complaint of snoring, witnessed apneas, daytime sleepiness, and she has GERD, polycystic ovarian syndrome, anxiety, and vitamin D deficiency. Medications include metformin, Zyrtec, and Dexilant. And we bring her in and we do a home sleep apnea test, and this is what we see. So she was studied for 7 hours. You have good oximetry, lead all the way across. Your pressure belts are good. You're able to see obstructions, mixed, but mostly hypopneas. The REI is 38.0 per hour. The minimum SAT 79. 17.1% of the time she is under oxygen saturation 90%. Remember, this is recorded time, so she's actually sleep time probably much worse, right? So this audience participation. What do you want to do with this lady? Do you want to? And here's your choices. Would you want to do a home CPAP titration and use put it with APAP in conjunction with LSPDX? How many people want to do that? Nobody. How about bring the patient in for a attended split-night polysomnogram? Bring the patient in the lab for CPAP, BiPAP titration? Really? Nobody's going to do any of these things? How about place patient on APAP with smart card download in 1 to 2 weeks? I actually think there's no right answer. I think that A is okay, I think B is okay, and I think D is okay. I think we pretty well confirmed that she has sleep apnea, so I don't think you should do B. But I think the truth is, I think any of those other 3 options are reasonable approaches. And so we actually did the first. We actually did APAP with PDX in conjunction, and we ended up finding optimal pressure of 15 with REI of 0.0. So our second study. This is a 40-year. I'm going to say, when you're doing these studies, remember what Lee Chong said? Know your patient, because this is important in the next 5, I'll guarantee you. 40-year-old patient with BMI of 56.6 and an ESS of 14. Chief complaints: frequent awakenings and daytime tiredness, hypertension and GERD, and medications include omeprazole, lisinopril, and hydrochlorothiazide. So we do that, and this is what we get. Now this is a trashed study. First of all, the oximeter is intermittent at best throughout most of the night, right? The effort belts have disappeared. The nasal cannula has disappeared. The thermistor has disappeared. What do you want to do with this guy? How many people want to do a split night study? All right. How many people want to do a CPAP titration? How many people want to bring him in and do a diagnostic? All right. That's probably a good answer, but we don't ever do the right thing, so this is what we do. We look at this. We actually analyze this data and say, is there anything salvageable? Well, first of all, look at these oxygen desaturations right out of the gate, right? You remember the patient? He had a BMI of 56. We probably shouldn't have been doing a home sleep apnea test, except this guy worked on the slope. He had just got to town. I know it's at least 2 weeks to get benefits advisory from Blue Cross Primera. Now we're talking about over a month before he gets studied. We're going to put a home sleep apnea device on you and see what we got, and then we'll deal with what we have. So we have 6.33 hours of recording, and even though we have all this absent information, we can still determine he has an RAI of 61. Does it really matter whether it's 200 or 60? Not really. And then, remember, even though we lost the oximeter, can we still determine apneas? Yes, we have 2 pressure belts, right? Now, what we can't determine is hypopneas because we can't determine 4% desaturations, right? But he has a mean oxygen saturation in the time that he's recorded of 83%, a minimum of 60. So what do you think this guy really has? Anybody? Yeah, he's obesity hypoventilation. So I take the approach that bringing him in and doing a diagnostic probably isn't going to help me a lot at this point. So my choice is to bring him in, and I would not do a split night to confirm this, because all of a sudden you do a split night, you lost 2 hours of time for your tech. So my approach is you bring him in for a titration, because reality, you're probably going to end up on APAP by the time you're done here. So you really want to give your tech the benefit of the doubt of having an entire night to do this. So that's my logic, whether it's right or wrong. That's how I treated this one. And remember, who are we satisfying with this? Who's paying the bill, right? So half of this game is, if this satisfies who's paying the bill, we already know we're going to do something with this patient. Case 3, 45-year-old male, BMI of 32.3, ESS of 12, and the chief complaint, snoring and daytime somnolence. He has borderline hypertension and no medications. So this is what we have. Actually a pretty good study. You know, we got different positions, we got good oximetry, we got good belts and good airflow monitoring. So a couple things. There's a few mixed, and I will say, I think it's harder to score on home sleep studies than it is in real studies, and you tend to have more mixed because they have a hard time determining sometimes. And there are a few centrals. So what do you want to do with this guy? Anybody want to just put him on APAP? Good. Anybody want to bring him into the lab and do a titration? Yeah, I think that's fine. I think that the answer is, retrospectively, should have brought him into the lab, because I didn't. I did a home sleep study, home sleep titration, again with, and so we have all this, and it's really hard to tell whether, I think in the lab you can tell more the nature of why we have the centrals. But remember, this guy really doesn't have a lot going on. He's a BMI of 32.3 and ESS, but he's otherwise in good health. So I think APAP would work, and I think bringing him into the lab, I think this actually just confused me, and I wasn't sure what to do with this at this point. But you can still, if you actually, I don't have the actual data underneath this, but I think we actually ended up putting him at a fixed pressure and then reevaluating. Case 4, 50-year-old female, BMI 42, ESS 11. Chief complaint, snoring, somnolence. Smokes 1 pack per day, and for 30 years. In my experience, that really means 1.5 pack per day is for 40 years. Ulcers, high cholesterol, hypothyroid, depression, fibromyalgia. Medications include Lexapro, Nexium, Zolpidem, Lipitor, Synthroid, and Buspar. This is what we have. So again, we lost our oximeter halfway through the study. Study for 8 hours. There's a couple centrals, a lot of mixed. But despite this, we know she's got at least moderate obstructive sleep apnea. It's interesting that despite her smoking and her morbid obesity, this really isn't that bad. So I think because I have a patient that's got a BMI of over 40 and mixed, I felt that this patient should come into the lab and have a CPAP titration. But I think we practice medicine. I don't think there are any strict rules, is the other part of this. I think when people make strict rules, they forget that the patient is who we're treating. Case 5, this is a good one. 50-year-old male, truck driver. BMI 37.4 and ESS of 6. Hypertension and medications include lisinopril. Pretty good study. Patient says, I tell him, you know what, you didn't really desaturate that bad, but you have severe obstructive sleep apnea. He says, no, he says, I don't have obstructive sleep apnea. He says, I went out on a bender last night and I got so drunk. He says, I just want a chance to repeat this study. Okay, because we're nice guys, this is what we do. RAI 4.1. What do you think happened?
Find his wife.
That's right. What was his motivation? He's not doing it for medical care. He's doing it because he has a CDL and he's a truck driver. That's why you have to have a chain of custody of some sort with these. And that's why I think, and Dodge talked about it, unless you have chain of custody, I think anytime there's a financial motivation either to have sleep apnea or not to have sleep apnea, I think we're bound to have to bring them into the lab and do it right now until there's a better technique. And I don't even believe the fingerprint stuff, because how do you make sure that the fingerprint and the person really are attached, you know? So we'll see. I mean, your wife could put her fingerprint, you know, I mean, that doesn't make sense. But anyway, so that was, and drinking heavily wouldn't have given you that curve anyway. You would actually had a variation in the amount of obstructions through the night. Case 6. 48-year-old male with BMI 37.4 and ESS of 6. Hypertension, chronic pain, medications include lisinopril, methadone, oxycodone. Referred for CPAP titration after undergoing an AIR study, home study, and was diagnosed with severe obstructive sleep apnea with the apnea-hypopnea index of 60 per hour. Don't tear my text apart on this too bad. But what do you think is happening on this one? Anybody have any ideas? Let me help you out. What does an AIRS device measure? Has no way of determining central from obstructive sleep apnea. This patient's on methadone and oxycodone. He had an AHI of 60, but he had central sleep apnea. And so he was sent in and they do a CPAP titration. Guess what? He still got central sleep apnea. Ooh. So know your equipment and know your patient and know what they're capable of doing. And as far as predicting the future of home sleep apnea testing, I put it right as the next quote under these. I don't think we know what the future of home sleep apnea testing is. I don't think it's the panacea. And all the studies done out there have been people that you already knew had sleep apnea going in it. They're a high probability of moderate to severe sleep apnea. I definitely think it's a tool that's here to stay, and I think it's a tool you can use in your armamentarium. I don't think that sleep labs, as we know them, are going out of business. They may be going out of business, but that's because they have bad business models. I think there will always be a need for in-lab sleep studies. And in our case, we do about 40% home studies and about 60% in-house studies. So I don't know what the future is. Questions? Yes?
I had a discussion with several people. I'm not going to name any names.
All right.
I just kind of wanted to see what your take on this is. What are your thoughts about just screening with pulse oximetry, overnight pulse oximetry?
There's data that shows it's actually pretty effective. But I'm not sure that we're doing a pretty good job of screening by looking at the patient also. So I don't know. What's your opinion on that?
Well, right, I mean, if it's positive.
Yeah, if it's positive, it's certainly beneficial. But remember, you can have bad obstructive sleep apnea and have no desaturations. And there's always that debate, if you're at chest conference, there's a debate about the effects of, is it the hypoxia of sleep apnea that gets you in trouble, or is it the obstructive sleep apnea? And the answer is probably both, right?
The answer, this is a kind of a practical question. Here I am trying to justify, sitting face to face, trying to justify giving study you at home or in the lab for sleep apnea. And they're looking at their checkbook and saying, wait a minute, this is going to cost me out of pocket, even though I'm insured, $500 to $1,000 out of pocket, depending on where their deductible is, et cetera. So, I mean, you can do a relatively cheap, by a magnitude of 10 maybe.
Well, I think the magnitude between oximetry in a home sleep study is not a magnitude of 10. I don't think it's that severe, but it's probably 5. I will agree that it's probably a magnitude of 5. But the real question is again, you have to ask that question of, is it the hypoxia or is it the obstructive sleep apnea? Because yes, obstructive sleep apnea can cause hypoxia, but you can have, as you saw, severe obstructive sleep apnea that does not have hypoxia. And the literature shows that both are a problem. And you know, just the obstructive events causing the changes in your sympathetic system all night long makes it increased risk. Snoring alone, without even having an obstructive sleep apnea, increases the risk of hypertension twofold by the Wisconsin study. Any other questions?